HbA1c has long been a cornerstone in diabetes care, a simple test that reflects average blood glucose over the past 3 months. It helps clinicians monitor long-term control, assess treatment success, and guide therapy adjustments. Yet, despite its value, HbA1c is not perfect. Certain conditions can distort its accuracy, leading to misleading results. In such cases, alternative methods may provide a clearer picture, including fasting plasma glucose, oral glucose tolerance testing, fructosamine, glycated albumin, and continuous glucose monitoring. Understanding when HbA1c misleads is key to delivering precise, patient-centered diabetes care. Mr. Clark is a 70-year-old man with a 22-year history of type 2 diabetes. His diabetes has been poorly controlled for many years due to inconsistent medication use and difficulty following dietary recommendations. His most recent routine HbA1c, done 1 month before admission, was 10.5%, reflecting long-standing uncontrolled diabetes. 10 days ago, Mr. Clark was admitted to the hospital with upper gastrointestinal bleeding caused by esophageal varices. He required blood transfusions and stayed in the hospital for 5 days. During his pre-admission workup, his HbA1c was reported as 6.9%, a dramatic drop from his previous value. Feeling encouraged by this improvement, Mr. Clark now visits his endocrinologist, convinced that his diabetes has suddenly improved and asking to reduce his medications.
Mr. Clark, I'm glad to see you recovering after your hospital stay. How are you feeling today?
I'm doing better, doctor. And I've got some good news. My HbA1c dropped from 10.5% to 6.9%. That's a big improvement. I think it's time to cut down on some of these diabetes medications.
I'm happy you're feeling better, but let's talk about that HbA1c result. It may not be telling us the full story.
What do you mean? The number went down. Isn't that good?
Normally, yes. But in your case, the drop isn't due to better glucose control. It's because of what happened during your hospitalization.
You mean the bleeding?
Exactly. When you had the esophageal bleed, you lost a significant amount of blood. That means you lost many of your older red blood cells, the ones that had been exposed to high glucose for months.
So the new blood changed the result?
Yes. After the transfusion, your bloodstream was filled with new red blood cells that hadn't been exposed to your usual high glucose levels. This makes the HbA1c appear falsely low.
So my diabetes didn't actually improve?
Not yet. Your glucose readings during admission were still high, and your long-term control hasn't changed. The HbA1c is unreliable right now because of the recent blood loss and transfusion.
I see. So we shouldn't reduce the medications?
Correct. For now, we'll rely on daily glucose readings, and later we can use fructosamine or glycated albumin to assess your control until your red blood cells stabilize.
Thank you for explaining that. I really thought I was doing better.
You will, Mr. Clark, but with consistent treatment, not because of a misleading number. We'll work together to get your diabetes truly under control.
Mr. Foster is a 57-year-old man with a 15-year history of poorly controlled type 2 diabetes. Over the years, his diabetes has progressed to chronic kidney disease, now classified as stage 3B, with an eGFR of 35 ml/min, 1.73 square meter, and an albumin-to-creatinine ratio (ACR) above 300 mg/g. Recently, Mr. Foster became frustrated with his diabetes care. He believed his previous physician was withholding essential tests, especially the HbA1c, and discontinuing medications he thought were necessary, including metformin. Feeling dissatisfied and misunderstood, he decided to seek care from a new doctor. Today, he arrives at the clinic with his most recent lab results, hoping for a different approach.
Good afternoon, Mr. Foster. I see you've brought your recent lab results. Before we go through them, may I ask, what made you decide to switch physicians?
Well, doctor, I felt like my old doctor wasn't taking my diabetes seriously anymore. He stopped some of my medications, including metformin, and he didn't even order an HbA1c test. I've been on that medication for years. It didn't make sense to me.
I understand why that would worry you. It's completely reasonable to want clarity about your treatment. Let's talk through each of those decisions together.
I just want proper care. I don't want things to be missed.
And you deserve exactly that. Now, I've reviewed your labs. Your eGFR is 35, and your ACR is over 300 milligram. That places you in stage 3 by its chronic kidney disease. At this stage, your previous doctor made decisions based on safety, not neglect.
Safety. How so?
Let's start with the HbA1c. In advanced CKD, HbA1c becomes unreliable. Your kidneys affect red blood cell lifespan, and many patients develop anemia. This makes the HbA1c falsely low, even when glucose is high. So your doctor wasn't ignoring your diabetes. He was avoiding a test that no longer reflects your true control.
So the HbA1c wouldn't help anymore.
Exactly. In your case, it could mislead us. Instead, we rely on daily glucose readings, and the best option for you is a continuous glucose monitoring sensor. It gives a real-time picture of your glucose patterns, which is far more accurate for someone with your kidney function.
And what about stopping metformin? I've been taking it for years.
That decision was also based on your kidney function. When the kidneys weaken, metformin can build up in the body. In rare cases, this can lead to a dangerous condition called lactic acidosis. Your doctor stopped it to protect you, not to deprive you of treatment.
So he wasn't neglecting me. He was trying to keep me safe.
Exactly. And now that you're here, we'll continue that same careful approach. We'll focus on medications that are safe for your kidneys and use a glucose sensor to monitor your diabetes accurately.
I appreciate you explaining all this. I really didn't understand what was happening.
That's what I'm here for, Mr. Foster. You're not alone in this. We'll manage your diabetes and kidney disease together, safely and effectively.
Conditions affecting red blood cell lifespan. But 1C depends on RBC survival 120 days. Anything shortening or prolonging RBC life makes it inaccurate. Examples: hemolytic anemia, acute blood loss, recent transfusion, hemoglobinopathies with hemolysis, such as sickle cell disease, hypersplenism. These conditions lead to falsely low HbA1c. Some hemoglobin variants interfere with lab assays. Examples: HbS, HbC, HbE, HbD, thalassemias, G6PD deficiency due to hemolysis. These hemoglobin variants can lead to falsely high or low depending on the assay. Chronic kidney disease, especially in advanced CKD or dialysis, affects the level of HbA1c as a result of carboxylated hemoglobin, anemia of CKD, erythropoietin therapy, frequent transfusions. This usually leads to the fact that HbA1c underestimates glycemia. In liver disease, particularly when cirrhosis develops, it leads to altered RBC turnover. This falsely leads to low HbA1c. During pregnancy, RBC lifespan decreases to 90 days. Also, rapid glucose changes make HbA1c slow and misleading. This makes HbA1c not reliable for diagnosis or monitoring gestational diabetes. Whenever there is a recent changes in glycemic control, HbA1c, which reflects 3 months average, lags behind reality. This is particularly after starting insulin and after acute illness, after steroid therapy, and after bariatric surgery. Iron deficiency, anemia, leads to longer RBC survival. This in turn leads to more glycation, resulting in falsely high HbA1c. High-dose vitamin C or E interfere with glycation or assays and can lower HbA1c artificially. HIV patients on certain ART medications, such as dapsone, ribavirin, and antiretrovirals, cause hemolysis. This leads to falsely low HbA1c.